Hello, my name is Dr. Dewan S. Raja. Today I will discuss about the osteology of the femur. The femur is a long bone. It is the longest bone and the strongest bone of our body. It is about 45 centimeter in an average adult male. Its length is about 1/4 the height of an individual, so it varies from person to person. So what is the anatomical position and how can we determine the site? So the rounded head of the femur, this is the rounded head of the femur, is above and is directed upwards, medially and slightly forward. Okay, the lower end of the femur, here is the lower end of the femur, has two large condyle, the medial condyle and the lateral condyle. Okay, the shaft of the femur is convex anteriorly and is directed obliquely downward and medially, and the lower surfaces of the two femoral condyle lie in the same horizontal plane. Okay, the shaft is cylindrical with a bony ridge called linea aspera on the posterior aspect. Here is the linea aspera on the posterior aspect of the shaft of the femur. So upper end has head, neck, the greater trochanter, here is the greater trochanter, and lesser trochanter. The head articulate with the acetabulum here, head articulate with the acetabulum of the hip bone and forms the hip joint. That is a ball and socket type of synovial joint. This is the ball, this is the socket type of, so this is the ball and socket type of synovial joint. The head has a small depression, we call it fovea. Okay, if we go there, this is the fovea here, head, the depression, it has attachment of a ligament of the head of the femur. Okay, so the neck is about 5 centimeter in length. This is the neck of the femur, is about 5 centimeter in length. It connects the head to shaft at an angle of 125 degree. The neck has two surfaces, anterior and posterior, and two border, upper and lower border. Okay, so if we just go through that part, the upper part of the femur, then we have the head, neck, we have the greater trochanter here, we have the lesser trochanter, intertrochanteric crest posteriorly, anteriorly intertrochanteric line, posteriorly over just above the middle of the intertrochanteric crest, we have the quadrate tubercle. Okay, we have the on the lateral aspect we'll get the gluteal tuberosity, and on the medial aspect we'll get the pectineal line. Okay, so we got, and this is the fossa on the medial aspect of the greater trochanter. Okay, we got that. So let us find out that head, fovea of the femoral head, neck, greater trochanter, lesser trochanter, intertrochanteric line anteriorly between the greater trochanter and the lesser trochanter, intertrochanteric crest posteriorly between the greater trochanter and lesser trochanter. Okay, trochanteric fossa is on the medial aspect of the upper part of the greater trochanter. Quadrate tubercle again just above the middle of the intertrochanteric crest. We have the pectineal line here just below the lesser trochanter going towards the linea aspera, and we have also the pectineal line, the gluteal tuberosity from the lateral aspect going towards the linea aspera. Okay, so this is the gluteal tuberosity here, the gluteal tuberosity, and this is the pectineal line, and this is the linea aspera. Okay, this is the lesser trochanter, greater trochanter. This is the neck of the femur, head of the femur, fovea of the femur. Okay, we got, this is the trochanteric fossa here. We get trochanteric fossa. Okay, here's the trochanteric fossa is here. Okay, we got that. Now go to the next slide. Okay, So here we'll identify some muscles here, like that of this is the muscle, gluteus medius muscle. It will go to the greater trochanter, will go there very soon. Gluteus minimus also goes to the greater trochanter, and we have the piriformis muscle here going towards the upper part of the greater trochanter. Then we have the gemellus superior, obturator internus, gemellus inferior, going to the inner surface of the greater trochanter in the trochanteric fossa. Okay, we'll go there, and here is the gluteus maximus muscle. It mostly inserts to the gluteal tract. Also, it inserts to the gluteal tuberosity. Is the gluteal tuberosity. Okay, we got that. So here we are looking at the anterior aspect. You will getting the muscle, the psoas major muscle, iliacus muscle. They are inserting to the lesser trochanter of the femur. This is the intertrochanteric line here. Okay, we got that. Ligament of the attachment to the head of the femur is the ligament of the head of the femur. Here is the ligament of the head of the femur to the pit here. There will be attachment of the capsular ligament along the intertrochanteric line. Muscular insertion to the greater trochanter, gluteus minimus to the anterior surface, okay, gluteus medius to the lateral surface, superior gemelli, obturator internus, inferior gemelli to the medial surface, piriformis to the upper border, obturator externus to the trochanteric fossa. Okay, so this is the superior gemelli, obturator internus, inferior gemelli to the medial surface of the trochanter, and on the trochanteric fossa we have the obturator externus muscle insertion. These are inserting there. Okay, attachment to the lesser trochanter is psoas major and iliacus. Here is the attachment of the psoas major and the iliacus, just medially a bit lower. Okay, attachment to the intertrochanteric line, origin of vastus lateralis. Here is the origin of the vastus lateralis, origin of vastus medialis. Okay, here, and we have also capsular ligament of the hip joint, and certainly we have the iliofemoral ligament attachment to the intertrochanteric line. Iliofemoral ligament, we know that iliofemoral ligament is also connected to the inferior iliac spine of the hip bone. Okay, attachment to the quadrate tubercle is the quadratus femoris muscle. Okay, osteology of the femur, attachment to the shaft of the femur. This is a big structure, a lot of muscle inserts there. Vastus intermedius, it is vast origin from the interior surface and the lateral aspect of the femur. Articularis genu, that is actually, this is the vastus intermedius. Then we have the articularis genu, that is usually one slip, but maybe more than one slip, we call it articularis genu. If it is only one slip, we call it articularis genus. It is usually underneath the vastus intermedius. It is told that it is a part of vastus intermedius by some anatomists. Vastus lateralis, vastus medialis, we have gone through that part. Vastus lateralis, vastus medialis, origin here from here. Okay, and gluteus maximus should origin from the posterior aspect, from the posterior to the posterior gluteal line here of the hip bone we have just discussed previously, and the gluteus maximus insert on the femur onto the gluteal tuberosity, but most of the fiber goes to the iliotibial tract. Okay, adductor magnus, very long insertion. It goes up to the linea aspera and the medial supracondylar line into the adductor tubercle. Okay, the adductor magnus. Pectineus goes to just below to the lesser trochanter area along the pectineal line. Adductor brevis also inserts in the upper part of the linea aspera. Adductor longus longer than just below the adductor brevis area of insertion to the linea aspera. Short head of biceps femoris also takes origin from the lower half of the linea aspera. Gastrocnemius take origin by two head. One is lateral head from the lateral epicondyle area. Okay, medial from the medial epicondyle area, plus a part goes from the extending to the popliteal surface of the femur, plus it also takes origin from the capsular ligament, the medial head. Okay, plantaris takes origin from the just on the lower part of the lateral supracondylar line here. We'll get it very soon. Okay, plantaris just above the lateral head of the gastrocnemius, and we have also attachment to the linea aspera, lateral medial intermuscular septum. Okay, so just look at that. This is the insertion of gluteus medius. It is on the lateral aspect. This is the insertion of quadratus femoris to the quadrate tubercle. This is the insertion of the iliopsoas to the lesser trochanter of the femur. We have the insertion of the pectineus along the pectineal line, the lower part of the lesser trochanter going towards the linea aspera, but going short of that. Okay, we have the gluteus maximus, the gluteal tuberosity, but most of the fiber inserts to the iliotibial tract. This is the adductor brevis muscle insertion here. Okay, then vastus medialis on the medial aspect, short head of the biceps femoris muscle here. Okay, takes origin from this part, from the middle half of the linea aspera, and long head should come from the ischial tuberosity and the ramus of the ischium. Okay, we got that. And this is the vastus intermedius here, even very large origin, and this is the adductor magnus going to the adductor tubercle here. Just close to it we have the origin of the medial head of the gastrocnemius. Here we have the origin of the gastrocnemius lateral head, and from the lateral aspect of the lateral condyle will get the group for the popliteus, and from the anterior part the popliteus muscle origin. When there is full flexion, it covers the entire group. Okay, we got that. So these are the muscle, vastus muscle and articularis genu. These muscles are innervated by what nerve? By the femoral nerve. Adductor muscles are innervated by what nerve? By the obturator nerve. The gluteus maximus is innervated by the inferior gluteal nerve. Gluteus medius, gluteus minimus are innervated by the superior gluteal nerve. Okay, we got that. The piriformis should be innervated by the nerve to the piriformis. Quadratus femoris should be innervated nerve to the quadratus femoris. Okay, we got that. And we have the nerve supply to the gemellus superior and obturator internus. That is getting nerve supply from nerve to the obturator internus. Okay, nerve to the quadratus femoris also innervates the inferior gemellus. Okay, we got the nerve supply. Then we'll go to the next slide. If you go there, again we are identifying the muscle. Okay, so this is the muscle sartorius. It is from the anterior superior spine going to the tibia. Okay, that is not connected to the femur. Okay, femur we have the muscle, pectineus muscle, adductor longus muscle. This is the vastus medialis. This is the vastus lateralis, and underneath the rectus femoris we'll get the vastus intermedius muscle. Okay, and this is the insertion of the adductor magnus. There is a gap here, we call it adductor hiatus, for the passage of the femoral vessels. The femoral artery becomes the popliteal artery, and the femoral vein and the popliteal vein becomes the femoral vein. This is the adductor hiatus. This is a gap in the adductor magnus muscle. Okay, this is the adductor magnus here. This is the adductor longus. This is the pectineus muscle. This is the adductor brevis muscle. Okay, these muscles are supplied by the obturator nerve. Pectineus may also get innervation from the femoral nerve. Okay, we got that. Okay, attachment to the lower end of the femur will go there. Lateral head of the gastrocnemius near the lateral epicondyle. Okay, so lateral head of the gastrocnemius near the lateral epicondyle, origin of the popliteus in the anterior part of the popliteal groove here, in the popliteal groove here. Okay, so it will be in the popliteal groove here. Okay, so here is the origin of popliteus muscle, and there will be attachment to the epicondyle, lateral epicondyle, the fibular collateral ligament. Medial contact, we have the adductor magnus, insertion, medial head of gastrocnemius from the medial epicondyle, plus a part to the popliteal surface, plus it is coming from the ligament. Of origin, it is also from the capsule and ligament, it also takes origin. Okay, the medial head of gastrocnemius, then epicondyle, medial epicondyle, site of attachment of the tibial collateral ligament. Okay, attachment to the intercondylar fossa, anterior cruciate ligament to the posterior part of the lateral wall of the intercondylar fossa. So this is the intercondylar fossa. This is the posterior part. This is the posterior part. So anterior cruciate ligament is attached to the posterior part of the lateral wall of the intercondylar fossa. Here, posterior cruciate ligament is attached to the anterior part of the medial wall of the intercondylar line. Okay, if the intercondylar line is above that, okay, this is the intercondylar line. Okay, if we go there, here is the intercondylar fossa is here, and this is the above the intercondylar line is here. So this is the intercondylar line, and this is the fossa. Okay, we got that. Okay, so we got the attachment of the posterior cruciate ligament. Intercondylar line gives attachment to the capsular ligament of the knee joint and the oblique popliteal ligament of the knee joint laterally. There is a synovial fold on the anterior border of the intercondylar fossa. Here is the anterior border of the intercondylar fossa. We have some synovial fold here. We have a synovial fold there. Okay, clinical note, femoral fracture is very common condition, especially in osteoporosis, especially in post-menopausal women. It will just fall, maybe very much trivial fall, not very severe injury that may lead to just turning body. In severe osteoporosis, that may lead to fracture of the neck of the femur. Neck of the femur is the most frequent site of fracture in elderly women after menopause. Femoral shaft fracture is less frequent. It is usually caused by strong trauma like a automobile accident or from violence. So shaft is very strong, so it actually resists fracture, but if the violence is very severe or very big trauma, it may be ruptured. So this image I have taken from the Microsoft PowerPoint online picture. Okay, so this is from Creative Commons. Okay, we have some other clinical notes. The coxa valga, increase in the neck shaft angle. This occurs in congenital dislocation of the hip joint. Adduction of the excuse me, adduction of the hip joint becomes limited. Coxa vara, decrease in the neck shaft angle. This occurs in fracture of the neck of the femur or slipping of the femoral epiphysis. Abduction of the hip joint is limited in coxa vara. Decrease in the angle become decreased here. This is 125. It will be less than 125. That may also happen in case of slipping of the femoral epiphysis. We call it slipped capital femoral epiphysis. It is usually seen in the adolescent boys and girls. Medico-legal importance of the secondary ossification area. Our femur has one primary center of ossification and 4 secondary center of ossification. One of the secondary center of ossification has medico-legal importance in forensic medicine, that is the secondary center of ossification, okay, area at the distal end at the 9th month of intrauterine life. So a baby is born, most likely baby was live born. Okay, so that is important medico-legally. And that's all about the osteology of the femur. If you have any question, please feel free to ask me. Please share the information with your friends. Please support my channel. Please subscribe me. Have a nice day. Bye now.